You might be missing a lot of patients in shock if you're waiting for the blood pressure to become abnormal. How can you avoid that pitfall? Come with me and we'll find out if your patient is on the bus. Shock is a clinical diagnosis based on the presence of hypoperfusion, not blood pressure. Along the same lines, not every patient with a low blood pressure is in shock. To determine if a patient's in shock, we should assess the bus parameters. Brain, is there altered mental status present? That could be depressed mental status, or that could be sort of anxiety, agitation, kind of can't get comfortable, looks bad. Urine output, has urine output decreased? And then the skin exam, is the capillary refill time abnormal? Is it more than 3 seconds? If any of these are positive, your patient is on the bus, and it's time to find out why. Side note, obviously there are other causes for these parameters to be abnormal, but if any of them are positive, you should assume shock is present until proven otherwise. Normotensive shock is a very commonly misdiagnosis due to the absence of hypotension. Patients with normotensive shock often have worse outcomes, and it might be just because we're late to recognize them or we don't ever recognize them. Normotensive shock is more commonly present in low stroke volume states. Think cardiogenic shock, pulmonary embolism, tamponade, and hemorrhage. It's also possible that you'll find patients that have a baseline very high blood pressure who develop relative hypotension and have hypoperfusion, and that person is also in shock. If you don't know how to assess perfusion clinically, you will miss these cases. That's why the bus assessment is vital. The same thing is true in any hypotensive patient. Are they bus negative? Maybe leave them alone. If the MAP is 55, but they're sitting up in bed eating breakfast and doing Sudoku puzzle, they probably don't need anything but observation. Does this change the way that you think about shock?